use the word genius to apply to his abilities. Dr. Hamid Abbasi, now a longstanding friend of mine, he is a neurosurgeon, and he's been a globetrotter, starting off in the Middle East and ending for some time in Germany and going through medical school there, but then further training in the States down in Texas. And not so long ago, it's going to be a few years ago, about a decade now, he's got interested in trying to innovate spine surgery so that instead of big open incisions on people's backs and multiple day admissions to hospital and all kinds of complications and failures, now doing things from I wouldn't say microscopic, but from a minimally invasive perspective. So it's kind of how we've gone from in gallbladders where we used to open up big incisions, and now we're doing things through little tubes and getting the same procedures done. Same thing we're doing in sports medicine where we're doing arthroscopic surgeries on joints. So he's taking that whole concept and reworking spine surgery, and he's one of the pioneers in all this. And so we're going to talk a little bit about what that represents and how it's transforming spine surgery, and about how people are reacting to it, both on the positives and the negatives of it, because not everybody wants to see this change.
No.
It's been interesting. So Dr. Abbasi, welcome.
Well, thank you for having me again here.
Yeah. So we spoke, I think, about 6 months ago. We had you on the air, and so how's the world transforming in the last 6 months? What's new and different?
Well, obviously, COVID is a big word now, and as a matter of fact, it seems that most of the hospitals are preventing of patient getting their surgery if it's not absolute emergency, especially because in spine ward, you do a surgery, patient stays there somewhere between 5 and 7 days, and that takes a lot of resources away from the hospital. And we know how scarce are the resources. As a matter of fact, I, as a neurosurgeon, our education never ends. I just yesterday, actually the day before yesterday, I did my annual exam in neurosurgery. Even for our board, neurosurgery board, spinal fusion is a 7-day hospital stay. Now, I'm sure you can understand that what we are providing in Crookston, that our patient going home within 24 hours, and many of my patients go home even less than a day after the surgery. We made a 7-day hospital stay, a day surgery, and that can open up significant amount of resources. And now we have a good understanding what it really means, that having those beds for people who have COVID.
Yeah, so having beds available for other things rather than laying in bed recovering from an operation.
Yeah.
So for those who didn't listen to the discussion 6 months ago, let's backtrack a little bit. So you are focusing on spine surgery, and within spine surgery, there's obviously a variety of different locations. There's the neck, there's the thoracic region or the chest region, and then there's the lower back. I would think that the lower back is probably the most common of the issues.
Correct.
And within that, there are a fairly broad variety of things that can go wrong. It's not all one thing going wrong. So if you could maybe elicit for the listeners the kind of things that can go wrong in the lower back, and then we'll kind of go through the big ones one by one and how we would approach them and then how we're treating them now.
Yeah. Well, as we discussed 6 months ago, our spine is made of bone and discs. They go back and forth all the way from skull to our tailbone. And in this sense, you can imagine that if you have more pressure, more weight on those segments, they have more wear and tears, and that's practically what's happening. With us aging like a tire of a car that have wear and tear, lower lumbar spine have more wear and tear than other lumbar vertebrae. And with the time, those discs, they don't do a good job in separating the bone. And the bone collapse, the material of the disc push on the nerve, and that can be extremely painful. It can be painful to a point that people start gathering their pills to end their lives. This kind of pain I'm talking about. And we can help them by restoring the anatomy and preventing the disc material to push on the nerve and literally making the pain go away and giving their life back.
So so you're saying the common element is the nerves being pinched or squished.
Yes.
There's some big words that get used in the lower back. Mm-hmm. So we have disc protrusions would be one, and that would be a pretty common thing, where it's maybe just more of the soft tissues are being affected. We also have spinal stenosis. So what's spinal stenosis, and how does that affect the back?
Well, spinal stenosis or stenosis as general in medicine, meaning that there's a narrowing. It could be a stenosis of an artery where not enough blood goes through, or it could be a stenosis of the intervertebral foramen where the nerve's root pass through, or it could be a stenosis of the spinal canal where the spinal cord goes through. In the spinal cord, there are few things that can make that space narrower. One is the content of the disc, like a bulging tire, flat tire comes out. Depending on how bad this is, we call it bulging disc or herniated disc. Or if it's separate, that piece separate, we call it sequestered disc. We have different name for different kind of appearance. But as well, the bone can grow in the wrong places. We call it a bony stenosis or osseous stenosis. And then we have the other possibilities that there's some tumor or other material close up that space. Either way, if the material that push on the nerves impeding the function of the nerve, that is where a surgeon comes in to open up that space.
So how is that patient going to present to you? What's happening to them at home on Saturday morning when they wake up and their back's hurting, or they go for a walk and they start getting discomfort? What are the typical symptoms of that patient who has spinal stenosis? And maybe the next big group of people who've got a bulging disc. How do they show up in your office? What are they telling you went wrong?
Well, every function we have at every level, in every place in our body, is based on the function of the nerves. And obviously, when there's a pressure, our body wants us to do something about it. So first symptom is pain. That pain can be depending on the activity, or can be just even at rest. That pain can be horrible. Like imagine hitting your funny bone on the table. Imagine now having that pain all the time. Now, if that problem cannot be resolved, obviously our functions start going down. First with how we feel, like numbness, tingling. Sometimes they describe they have burning sensation. And the most resilient nerve in our body are what we call the motoneuron, or nerve that carry the information to our muscle. For a good reason. If we cannot move our muscle, we starve. In nature, we starve. For that reason, they are very resilient. So the last thing, or the most dangerous sign, is when we start feeling weakness in our appendages, like legs and arms.
So these people, they're going to wake up, they got back pain. It could be burning in nature. Where does it go? Is there anything classic about that?
Yes, we call it dermatomes, meaning that our spine is organized that between every two bone and a nerve goes out, those nerves go in the neck to our arms and fingers. In the chest, they go to around the chest and in the belly area. And in the lower back, they go all the way down to our legs, meaning that, like, for example, if you have symptoms in the front of your thighs, there are upper nerves in the lumbar spine that are are being pushed. And if you have a problem in the foot, mostly the bottom two nerves are being pushed.
So there are some pretty classic locations where those can go to. The lowest one, the S1 nerve root, that's going to give changes in feeling along the side of the foot.
Yes.
The next one up, the L5 nerve root, can give some changes on the area between the big toe and the second toe.
Correct.
And then you've got the L4 nerve root, which is a little higher up. That one can give you some pain up even around the knee.
Yeah.
So there's some pretty classic locations where you look for when people were asking people, where does the pain go? And so being able to tell the doctor, where the location of the pain is can be very critical in the determination of what's going wrong.
Well, since we are talking about the dermatomal distribution, as well, we have S2 and S3. They go to genital and perianal area around our anus, and if that happens, people can describe that there is a numbness, or they don't feel it, or they lose their sphincter tone, or they become incontinent, and that is the dangerous. That's the alarm sign. If there is any of those symptoms, that has to be taken care of or looked at right away.
But those, fortunately, those are much less common. So the most
Correct.
common things are the things that do go wrong in the lower lumbar region, and those ones classically end up either in the front of the leg or down into the foot.
Correct.
So somebody comes in with that, and there are, like you say, the spinal stenosis patients. They also have some classic symptoms too, and one of them is that when they go for a walk, they develop increasing pain the further they go. And it's a term we use called spinal claudication or neurogenic claudication. So there's issues of the history that we focus on, not just about the patient's pain in their lower back. So let's say we got that patient come in, we're gonna take some x-rays, we're gonna see some degeneration. Obviously with plain x-rays, we can't see these more sophisticated issues like nerves being pinched by discs. We're going to usually go through a series of tests. And what tests would you typically recommend that somebody go through to fully evaluate their back?
Generally these days, MRI is a good place to start. Now, some people may have previous surgeries or metal in their body, and MRI would have lots of artifacts. In those cases, we get CAT scan, or if we put a little bit of a contrast, we get so-called myelogram. But generally these days, the 3D kind of picture like MRI or CT is the standard of diagnostic.
And so we're going to get, let's say somebody who we've agreed does have one of these kind of conditions. What's the next step for them typically in your hands? I know it's not surgery, so what's going to happen to them?
Generally, depending on the symptoms, there are some alarm signs that make us bypass all the things and go directly to the surgery, as we discussed, like what we call cauda equina, where we have bladder incontinence, you have perianal anesthesia, and so on. But beside that, we obviously try to maximize the body's capacity to heal the problem. And that's what I tell to my patient, that the disc is a living thing. Your bone, your spine is a living thing. Sometimes if you put it in a good position, good situation, it heals itself. And to do that, first of all, we ask them to avoid certain activity that's demanding to the spine. For those activities that they cannot avoid, like driving a car these days, it's hard to avoid that. We put them in a brace so that all those bumps on the road don't make the damage worse. And then we build up internal structure, internal bracing, which is our own muscle, with very specific kind of training, which is called physical therapy. And as well, injections can be helpful, where we put some steroid, and the steroid is a hormone your body produces when it's trying to heal things. By us putting that in the right place, it speeds up the healing process. If all of that fails, that is where the true skill of a surgeon comes in play.
So I grew up in a day when somebody had that kind of back problem. Sometimes it was, let's go take out the disc. Sometimes it was the whole thing was degenerative and all the little bones in the back were worn out. And we'd do what we call a fusion of the back. We'd lock some of these bones together so they didn't move anymore. And I know that that's really where you're trying to transform things the most. What was wrong with the old way? What happened? I know because historically there was always the people, I had back surgery and it didn't get better. It got worse. And then I had another back operation and that seemed to make it worse. And people, it got to the point where so many people were afraid of having back surgery because the results didn't seem to be that predictable. And if they were predictable, they were in a negative way. They were predicting that they would actually get worse rather than better. So what was wrong with that technique that we were doing back 30 years ago, 40 years ago?
Well, we still do that, and that's the best way I can explain it to you. You're yourself an orthopedic surgeon, and imagine you do a shoulder surgery and you just detach all the muscle and you don't reconnect them. That shoulder will be rendered non-functional. In the spine surgery, we have hundreds of the smaller muscle that goes from different area from one bone to another. Not only we cut those bones that the muscle are attached, we completely denervate, meaning they completely detach the nerve that goes to those muscles. And muscles that are without the nerve, they die, they become scar. Practically on the way of getting to the problem, which is the disc, in a regular open fashion surgery, for lack of other term, we defillet patient open and we never reattach those muscles, and those muscles lose their function. As a matter of fact, those muscles are giving blood supply to the bone, so bone doesn't get enough blood supply, so it doesn't heal. So old-fashioned surgery is barbaric, for lack of other term, in its own right.
There are still circumstances where it may be the most appropriate thing to do, but what you've now figured out is a way to get to those same areas without all that dissection where you're taking the muscles off and damaging the nerve supply and the blood supply to the bone. So briefly just discuss how you've taken this concept and what goes on now, and then we'll talk about how that changes the outcomes.
Certainly, there are situations that is necessary to do that, and those are the situations that our board is telling you stay 7 days in the hospital, and it takes you at least 2 or 3 days before you can even stand on your feet. Whereas my patients stand on their feet 2 hours after the surgery. Most of them are home within hours after my surgery because I don't detach those muscles. I don't destroy those structures that nature or anatomy put in place. And if the question is, who needs that kind of surgery, the diagnosis is the same that at least at this point as well, open surgeon, the surgeon who are trained to do this surgery open old-fashioned way, they are providing that. But the only difference is that we do entire surgery to a tube that is barely bigger than a pencil.
So
and the technology has come along.
Round little tube that goes down into the area of the surgery.
Yeah.
And then through that little tube, you put what?
First of all, I think the first step is that we don't cut the muscle. We just dilate the fibers of the muscle, and once we take the tube back, those fibers, they come back together, and practically virtually there's no scarring there. But then as well, this very specialized tool enable us to do the same job much better, much faster, with 1/10 to 1/20th of blood loss of the open surgeon. Most of the time, the surgeon just spending the time to cut the muscle, cause bleeding. Then we cook the tissue alive with bipolar or Bovi, we call them fancy names, or practically we apply electricity to cook the muscle to stop the bleeding. And then it takes us 1.5 hours to get in, and it causes lots of damage on the way of getting in. But with our path, within few minutes, we are where we need to be without all that thing.
So you have a little tube that goes down, you say you dilate, you push it
The
through the
muscle.
muscles, spread them apart rather than cut them.
Correct.
Get down to the location, and then you're able, and now this is being done not blind, this is being done with x-rays at the same time so you can know exactly where you're going.
Correct.
And then through that little tube, you're able to remove pieces of tissue that are putting pressure on nerves.
And restore the height of the disc, practically putting the anatomy the way it's supposed to be.
And the restoration of the height of the disc, where these discs have squished down, you're doing that with these little internal, we call them cages, I believe, and there's bone in them, and you can actually, they're kind of shaped like a bullet, and they can be pushed into the disc space and push the bones apart again. And then with that bone, that little bullet that's got bone in it, the disc then fuses.
So this is no trivial task. At any direction you look at it, this is a very complex task. You should imagine there is spinal cord next to it, aorta, vena cava, all major vessels, lots of nerves, arteries, and vital structures are in your way. This is has been truly a triumph of technology, science, and combination of all these different kind of discipline together to enable us to do that surgery within 30 minutes, sometimes even shorter.
When I first was training, and this concept of doing fusions in the front part of the back was just evolving. And we used to have a general surgeon come in, and the orthopedic surgeon would open up the back, and then we'd turn the patient over, and then they'd open up the belly to be able to get to the lower part of the spine. And then there was the major blood vessels and the nerves that are sitting right in that location that all had to be moved by the general surgeon before the orthopedic surgeon could finish doing the front part of the operation. And that was an all-day event.
Still is.
And still is in many, many locations. So the wonder of this technology is that it's now taken away all of the extra person that has to be involved. It's taken away the dangers of going in from the belly. It's taken away all the discomfort that comes from having your belly opened up while you're having a spine surgery. And it sped the operation up, like you said, from a typical 6 or 7 hour operation now down to 30 minutes, which is amazing.
Yeah, it is amazing, and we have data regarding that. We know that every additional half an hour, just under anesthesia, adds 17% to the combined risk of the surgery. Now, if you make an 8-hour surgery, a 1-hour surgery, you can imagine how much you're reducing the risks of the surgery. Surgeries that would be deadly for a 75, 85-year-old person, and the only alternative is living with the pain or not living with the pain, because then they decondition and die. Now we can help them. We can in a 1 hour surgery, we can restore their anatomy and make them independent, making them again able to participate in the family life.
So this technology is expanding and broadening the breadth of the patients who are now eligible for surgery. So if I understand correctly, the fusion rates are so much better that some of the older folks who we thought couldn't have these kind of operations because their backs wouldn't heal now are eligible. And because it's so much quicker, it's much less stress on them, so we can now do older individuals. And there's now also a broader range of the levels in the spine that you can accomplish this with.
Yeah, well, there is not a week or two that I don't get an elderly patient that has been told by Mayo, you cannot have that surgery, even bigger hospital like Mayo. Yet, right here in Crookston, we perform a 40-minute surgery. Yesterday, I did a 2 level surgery. Each of them were 42 and 45 minutes. Those patients most likely will go home. Now, this is the technology that has enabled us to make impossible truly possible now.
Yeah, so that's spectacular. We're taking on the cases that the Mayo Clinic would not want to do and be able to do them safely in a small rural setting and accomplish them so quickly that the patients are home within 24 hours of their operation. How has the response been nationally from the major centers, not just the Mayo Clinic, but the other major universities that are all been talking about their programs, and what kind of reception have you got from the I would say the fossilized group of people?
Now they say you cannot teach old dogs new tricks, and that's truly has been the case here. We are so far beyond their concept of how things can be done and what can be done that it takes a lot of training to be able to do that. This is by any mean is a triumph of technology and science, but it doesn't come cheap. It comes, you have to stop what you're doing, you have to get trained in it, and you have to literally go back to school. Yeah. Now, can you take 6 months off or 3 months off, go back to school, learn something new? It's a hard thing to do.
It's hard, yeah. But how impressive is it? Well, we had, as a guest here in Crookston, it's almost a year now, Dr. Kim from the University of Tokyo, who's the chief of the Japanese spine group, and he's also the head of the Asian Spine Society. And he came to Crookston last year just to see how this was done. And I had the opportunity to have a conversation with him, and he said it would take them at least 2 years if they spent every day to catch up to what Crookston is doing. Yeah. So it's really quite remarkable. So this is now, people are starting to notice a little bit. I understand you've had a few, some of the major networks have now found out about you and had some discussions. So what's been going on there?
More importantly, patients are smarter than ever. Internet has democratized the concept of getting information. We just had our patient from Canada who drove all the way from Canada to come to us to get the surgery done. We did the surgery, a same-day surgery, 2-level fusion that our board says is a 7-day hospital stay. Patient went out of the surgery center exactly 2 hours after the surgery and is already home, sending us the best regards and so on. And we are getting international attention. And that is, for me personally, is more important than what we are doing for our patient. But as well, I think slowly it's penetrating through our patient to major networks. That I just had an interview with Forbes magazine last week, and as well with 2 major TV. I think it's the word is going out there, and at the end of the day, our patients are going to be the people who are going to push this forward, because they are the true beneficiary of this.
There are other examples in historically in the spine or in the orthopedic world. The doctor who started doing joint replacements for hips built the first ones in his garage in a little town in central England, and then started putting them in a hospital not much different than Crookston. And so the very, very first total hip replacements were done by a doctor who had the insight and the willingness to try to push things forward. So here we have the same thing happening here in little old Crookston. We got somebody pushing something that's going to be world-changing. So it's really quite remarkable. So congratulations on the work you've been putting in, and I know it's been a lot of stress this last 5 or 6 years convincing people, but now that the proof is out there, I think the convincing is going to take less and less, and there's going to be the tsunami of people coming after you looking for help.
They already are, and we can do much better than garage. I have a really few thousand square foot real shop that I do that. I don't have to use my garage for that, but it's truly as well a teamwork that, we have a true campus in the cities where we have engineers and different people with different skills that within few weeks we can make changes, and we have put the right people in the right place to push this forward. We are sitting on something very big, and people here in Crookston and generally Minnesota and even the United States as a general will see differences coming to spine care. And spine care is not some rare disease. By the time you're 70 years old, there's only 2% chance you don't have spine problem. So this will have individual and personal impact on every person's life.
Remarkable. I so much look forward to how this is going to continue to progress and evolve. If you've seen how much change in the last 5 or 6 years, and the next 5 or 6 years, I think you're going to see an exponential change in it as well. So congratulations on what you've been doing. And people in Crookston, we've truly been blessed by having an opportunity to have absolutely world-class surgery being done here. It's totally innovative, that it is transforming how spine surgery is going to be done for the future.
Always my pleasure to be here.
All right, Dr. Ahmed Abbas, thank you for the time here today. And Dr. Fennell, is this the last show of 2020?
I guess so, because we're running into the week where we got Christmas Eve on the Thursday and New Year's Eve on the Thursday. So I'll be saying goodbye for now, and we'll be back in the new year and starting up. And according to Mr. Fee, we're actually going to be getting these onto the website pretty soon, and so people will be able to watch these or listen at least to these shows at their leisure, and starting in 2021.
Excellent. Yeah, we look forward to that and many other things in the year of 2021. Appreciate you both coming on today, and thanks for coming in.
Thanks very much.
All right, thanks for the information. That is Medicine Explained for this week. That'll be the final program of 2020. So thank you all for listening. As always, it's a little